As mentioned, I've been serving community hospitals and health systems for the last 5 years or so. Many of them recently have joined ACOs or thinking about joining ACOs or similar programs. And one of the questions that has really popped up in the last few weeks, few months from the more cutting-edge systems is, well, we know who the high-cost, high-risk patients are for our system today, but we don't know who they're going to be tomorrow, 3 months from now, 6 months from now. And it's an absolutely critical question, and one where most health systems will be looking in the coming months and years. If you recall, the Pioneer ACO program renewed a few months ago, and a number of health systems dropped out of the ACO program. They said, look, we had the right 5-year, 10-year plan for bending the cost curve among our patient population, but we just couldn't make the economics work in year 1 and year 2. And so that's the intent of today's presentation, to talk a bit about that topic. So if you're a member of an ACO or a similar model, you have to know which patients you're going to offer additional care to today. Tomorrow, do you offer it to Bill or Mary? You may have 10 or 100,000 patients in the population that you're caring for. And you have to, so who are the patients where your time is most efficiently spent, and how much can we bend the cost curve by providing additional care for them? So the talk is titled The Next Top 5%. A reasonable question might be, what's wrong with the current top 5%? So we'll talk about that. We'll talk about why this is not just an important problem, but a difficult problem. Arijit will then share some information about the methodology and the approach, and then the results. So today, ACOs and similar models offer additional care to what we call the top 1%. These are the highest risk, highest cost patients. They typically deploy care managers. Care managers work. That's been proven. They're tremendously effective. They often work through home visits. They do a number of tactical things. You can see some of them here. They do a number of more intangible things as well. Tactical things such as making sure that you're signed up to visit your primary care physician on a regular basis, that you have a ride, especially if you're in a wheelchair, that you are taking your medications, that you know which medications to take, that there's some coordination among your specialists. But also more intangible things, looking for symptoms of depression, psychosocial disorders, making sure that you have something like church that you can attend to provide some form of social support. So, care managers, tremendously effective. Many ACOs are deploying them. Where do we go next when we go beyond the top 1%? So you've probably seen this page. This is the famous inverted pyramids. On the left, we have the population as is ordered by risk. The very top row, a very small number of very high-risk people, and then going down to the bottom, a large group of very healthy people. And the high-risk people are, on average, very expensive. And going down, of course, the healthy members of the population, much less so. So it's clear, and it has been clearly said, apparently, that really the approach here is you first start with the top 1%, then you move down to the top 5%, and so on, as we offer additional care and care coordination. But this is the page that you know. This is the page here, then, perhaps, that you might not know. And this proves that individuals don't follow the averages. Averages are good. Risk scores are great. They work very well for health insurance companies looking to adjust payments for broad cohorts of the population. They do not help us identify Bob or Mary, because you can see here within the top 1%, that top line, the average is on the far right, but there are a number of patients in any given year that are relatively inexpensive in the cost of their medical care, and so on down. So if we're looking for Bob or Mary, risk scores, unfortunately, aren't the solution. A second approach is we could say, well, let's just look at the most expensive patients today. So again, this is a chart you've probably seen. This is organizing the 200 million commercially insured population from, on the far left, the absolute least expensive in terms of total medical cost, to the most expensive, and bucketing them into 5% groups. And indeed, the top 5%, the 5% highest cost patients, account for half of the total medical spend in this country among the commercially insured. So shouldn't we focus on them? Well, that's the chart you've seen. Perhaps the chart that you haven't seen is that the top 5% is a very fickle club. You have a heart attack, you go through post-acute care, and hopefully you go back to a normal life. The vast majority of these patients are cycling in and out of being members of this top 5% club.
And if I may add something, in general, if you think of the approach, this is the difference between how marketing looks at data and sales looks at data. Marketing is trying to look at broad movements of population. If you're looking at risk, if you're thinking of big allocations, you think of broad movements of population. You talk to a sales guy, he talks about who are my top 5 accounts, right? These are the specific things I got to do to close some deals today. That's the difference. If we can get specific to the Bob and Mary that Tim is talking about, that's how we have the effect.
Absolutely. Yeah, that's a great analogy. And one more slide then in this section. What if we were to plot each individual in the United States and their year-on-year cost from year 2 divided by year 1? And this is what this is. And you see that the vast majority of the population don't change costs from one year to the next. That's that big spike in the middle. But there are 5% whose costs increase by more than $10,000, and there are 3 to 4% whose costs decrease by more than $10,000 from one year to the next. It's that group that are increasing by that substantial amount that is particularly interesting to us here.
And, this is a little bit of an unscientific approach, but imagine we are playing an origami game, Think of that graph and fold it in half, right down the middle. You'll see that the left-hand side and the right-hand side kind of balance each other, but that 5.2 on this one end is really a problem compared to the 3.6 on the other. If we can get that 5.2 down to 3.6 or lower, maybe we can stop the growth in healthcare costs. That's what we are trying to do. How can we target an actionable set of subpopulations where we can bring down the cost of the overall system without making it a humongous undertaking? So what exactly did we do? This is one of my favorite quotes from Sherlock Holmes. And I really find that when we look at data, we are playing detective. The problem is, what's the first thing you do when you analyze data? Figure out the questions to ask. Agreed? If I go in and graph something, there's a question I'm asking that I'm graphing. If I'm doing a statistical analysis, there are certain data points that we are looking at, certain variables we are adjusting by. That's a question. That's a hypothesis. And that's what Sherlock was talking about when he talks about building premature theories. In his case, insufficient data. In our case, a deluge of too much data. But the problem is the same. Is that fair for everyone? Fundamentally, let's say I have 10 variables to look at and one outcome variable, which might be patient length of stay. If I'm looking at one variable at a time, I have to look at 10 graphs. If I have to look at 2, I have to look at 90 graphs. If I want to look at 3 variables at a time, 720 graphs. This is an exponential problem. You cannot solve an exponential problem by throwing a linear solution, which is let's make people work very, very hard. Is that fair? Does everybody agree? Okay? Let's just go to the world of big data. The problem just became crazy. When you're up here looking at 10 fields first order, yeah, you could kind of do that. You can putter along as you get to 100 fields. The moment you get to 200 fields and 4 variables, you're at 4 billion variable combinations. You're not going to solve this problem by working harder. Too much focus has gone into the size of the data. It's actually technologically feasible to make data access fast. The bigger problem is the complexity of the data because you can't analyze so many things that fast. What we looked at was a little bit more than 100 variables, and we did it at second and third order. So the orange box shows you what was the scope of this analysis. Tim, would you like to add anything?
No, that's absolutely right. From my world, we actually come from the world of a black room where we have a dark room where we have a handful of analysts, and trying to solve an exponential problem by throwing more analysts at it is a linear solution. And in this case, Arjit and I were working on this project not as part of a client-funded exercise. We did it because we both really cared about this topic, and we didn't have one full-time analyst, let alone a room full of large analysts, so we did need some additional tools. Here are the fields that we looked at. We followed 30 million patients over the course of 3 years, and we used an inpatient trigger events. You have to, if we talk about the increase in cost from one year to the next, we have to have some trigger event. We have to have something that differentiates one year from the other, not January 1st, but something important to the patient. And we found that inpatient events were actually the most effective at this. You're in the hospital for a while, you transition to post-acute care, there's a lot of coordination, there's a lot of handoffs that have to occur. Our health system is not very good at that. Care managers can help. And so these are some of the fields that we used here. What we talked about this, really, which is, if I had done this on my own, This is this is roughly what would have taken me and a couple of colleagues, probably 7 or 8 months for a data set of this size, the data preparation, hypothesis generation, iterative cycles of analysis, and then in the end of the day, we would have been able to do a finite number of analyses, and we wanted to do more with less. In fact, frankly, we had to.
And one quick question, people in the room, do you think Tim's estimate is about right? Would it be about 8 months, 250 variables, approximately what he would have done? Or do you think he could have done more? With analysts looking at data, trying to figure out regression models, trying to figure out what variable combinations matter. With 1 million potential variable combinations, more than 100 variables to consider. Does that sound about fair? I see some people nodding their heads. Okay,
yeah.
Please.
Yeah. So, well, I think that's largely the intro part of this talk here, which was what the problem we're trying to solve, why it's important, why it's difficult, why some traditional methods wouldn't work, at least in our situation, weren't going to work. Arjit will now do a 2 or 3 minute demo of some of the tools. He said he'd do it in 3 minutes or less, so we'll hold him to that. We're doing the demo not because we're saying these are the tools that you should use by any stretch. I think what we didn't want to do was to come up here and talk about a really complex, hard problem and all these variables, and then hand wave over the middle bit and then talk about the results. So this is not a magic show. We wanted to beam in here to some of the tools and approaches that we used here.
So one of the things before I start, at BeyondCore we say simple is hard, we do simple. But one problem of making things simple is then people say, oh, that was trivial. I could have done that on an Excel spreadsheet, right? So you're going to see two things. You're going to see something very simple up front where we are going to go and say, what is the driver of per member per year cost or per member per year cost growth? And at the end of the 2.5 minute video, you're going to see something which says, here is the prioritized list of things I should do. In the middle, you're going to see a lot of complexity. That complexity is primarily there, so you know we didn't do a magic trick. We loaded up a CSV file. In this case, the data set, even 30 million, actually was exportable in CSV. And we had the software introspect the data, figuring out what variables matter. PMPI total was one of the variables we picked. And the software automatically goes in through variable combinations. This is the importance of hypothesis-free analysis, because you can run through lots of, ask every question. And it comes back, and it actually does talk to you. The audio, I don't know, it's not working. But it talks back to you, telling you what's interesting and which parts of each graph you should look at. The interesting thing in this case, the software said the same thing we might have guessed. Hospitalizations were the biggest driver of cost. So we pivoted on cost before and after hospitalizations. What was the cost increase? And these are all the variables we were looking at. And the only click was I chose PMPI growth as the outcome I wanted to understand and get going. So it comes out with multiple variable combinations it thinks is interesting. It grays out areas that are not interesting. Here we are looking at where does anemia matter. For which diagnosis does anemia matter? It guides us to which variables, which diagnosis we should focus on. And you can see these graphs. There's also a regression model that's being created. So a typical regression model might have 20 to 50 terms. Now, in this case, we built something with 5,000 terms. The graphics I'm showing you on the screen is 1,000 terms. And you could move it around. If you're concerned about overfitting, you could change the nature of the model to reduce overfitting. You could take out variables. You could reduce the number of terms. But why did we do this? So that there is an understanding of the data that the software gains. And once we have agreed on a model, we can go ahead, and it's, as you can see, you can pretty easily change this, but most humans wouldn't look at that. They would click the first thing and see the final result. So we see a high PMPI increase in something called fistula, and the software goes in and explains what was the drivers of that behavior. And here's the interesting thing. I had a funny debate yesterday. The software says these guys also had chronic kidney disease. So a doctor yesterday told me, that's obvious. Everyone knows if you have fistula, you have chronic kidney disease. Well, I didn't. The software figured it out automatically. So you should be happy that the software figured it out without getting years of medical training, because that means what model it presents is probably more accurate. The final thing we said, let's look at a patient population on the left, which is the opportunity group, patient population on the right, which is the benchmark group. What's the difference between them? The amount of antidepressant they're taking in this case. And what's the difference? $8,000. That's the kind of very simple insights you want to give people, because they don't want to know about regression. They just want to get something they can act on.
Thank you, Arjit. So finally, so now to the results. We have about 5-6 pages of results. we'll spend a little bit more time on this, the more interesting half of the talk, hopefully. So one of the first things that the analysis came back with was this. I'll share this. It's an interesting microsegment. It's not the most interesting microsegment, but it's a nice one to talk to, and it's a good example to walk through in a bit of detail. So, if you are a commercially insured individual, you go into the hospital for an inpatient admission. On average, your costs from the year following your discharge relative to the year prior to your admission, not counting the cost of the inpatient admission itself, will be $4,200 higher. That's those are the post-acute care and the getting back to a normal life costs. Analysis came back and said, well, it's actually more interesting to build microsegments out of that. The first way you might build a segment is to look at heart failure. That's actually, if you were to choose one variable, that is, you could do worse than to look at heart failure. And so if you are a patient with heart failure, your costs are expected to increase $17,800 from one year to the next. In addition, so heart failure is an organic disease, a chronic disease. If you layer on top of that a mental health issue, so the analysis came back and said, here the most interesting and the most predictive flag is whether you've taken antidepressants at some point in the prior 12 months. And if that's the case, your costs, in addition to heart failure, your costs now are going to increase $22,000. It's mental health plus organic disease. I think is well known. This is not a blockbuster result, but the quantification here is interesting. And the reason for it is, as you probably know, depression, other psychosocial issues make it difficult sometimes for you to take care of your own health. It makes it difficult for others to help you take care of your health. And then finally, the analysis came back and said on the third order, the most interesting microsegment of all in this decision tree here is not just to look at those who are taking antidepressants, but actually let's see how well they adhere to their antidepressant prescription. So those who are taking it less than half the time, your costs are now increasing $33,000. At $33,000 for this. It's one person there compared to the 250 people at the top. It's a small microsegment. Relatively an important one, and you see $33,000 relative to $4,200. So in general, as we look at these microsegments, and this is one example of one, it's an interesting one, it's not the most interesting one. There are a million of them, we asked two things. So one, this is an interesting microsegment. What are the top 10 most interesting microsegments? That's what we'll answer on the next slide. That was the question we asked. And the second question that we asked, analysis can't do this, but we worked with our physician colleagues, and which was, what's actually actionable here? In this case, is this actionable? I don't know. I'm not claiming that it is. I'm not claiming that if we took these people who are taking their antidepressants less than 40% of the time and we moved them over to a stronger adherence, that we'd actually see that change. I can't claim that. But there are certain microsegments where we can say, yeah, these are actionable. There's a set of activities that a care manager can walk you through, and we can claim that we can get this $33,000 or whatever the cost increase is down substantially through care coordination. Any additional thoughts you want to make, Arja, as a statistician here?
So the main thing actually you want to give the disclaimer slide out.
Oh, yeah.
I guess we should explain what we did and what we didn't do. Every one of these things were statistically significant, firstly. Secondly, when we are looking at antidepressant use, it's not just whether you're depressed or not, because antidepressant use before heart failure was not predictive of this difference. Antidepressant use after the heart failure was. So there was something interesting going on there. Secondly, it wasn't just a matter of do you take your meds, because the other medicines were not as predictive of this outcome as antidepressant was. But as Tim pointed out, there is a difference between a clinical trial and a statistical approach like this, but these can be great indicators of things that are almost certainly going to be actionable, but not guaranteed to be so.
Okay. Good, thanks. Well, let's get to the top 10 list then. So far in our talk, we've talked about there's a complex problem. It's an important problem. We've talked about the methodology, and we've given a specific example of how of an output of what a microsegment looks like. So here, well, it's actually 7, not quite a top 10, but these are the top 7 microsegments that came back from the analysis that were vetted by the panel of physicians. So there's a lot on this page. I'd like to spend a couple minutes on it, and I'll talk through it a little bit.
If I may add one thing, it's 7 out of 5,000 that we started with.
Yeah, if you want more, there's more. This actually isn't quite the top 7. I took a couple out, and I added in number 14 just to pull in some ones that are interesting to talk over. But what you first, I'll talk over what's on here. But I think the first thing that the first point I want to make, the first thing that I hope pops out here, is that across these 7 microsegments, the year-on-year cost increase averages around $60,000. The guy at the top is a little bit more, and the bottom, but it averages around $60,000. And the size of the microsegments is here is this column on the far right. So for the first row, these complex patients who don't see a doctor, your average 500-bed hospital will see 4 to 5 of these patients every year. If you add up all the patients in this top 7, you end up with 19 total patients. 19 total patients whose net total cost of care is going to increase by $1.2 million the year following their discharge versus the year prior to. And so this is exactly where care managers can be effective. And we can talk about how they can be effective in any of these given different ways, but how they can be effective in each of these particular microsegments. Can we get that $1.2 million down to zero? Probably not, but can we make a substantial, can we decrease it substantially? Yes, the panel of physicians really believes that we can. And, and it doesn't, and this is only 20 patients, so one full-time care manager, if things were balanced well, might be able to spend a substantial amount of time with each of these 20 patients over the course of the year. So I think, and I'll talk about the things in detail here, but something that Arjit said a couple days ago, I think is exactly right. That he hears, I hear it as well. We hear a lot in healthcare. You probably hear it. That everyone knows there's opportunities out there. Everybody. In a sense, we're kids in candy stores sometimes. I'm not a healthcare provider. I as a consultant, as an analytic lead, I sometimes gloss over how hard things are to implement. I understand that, but the question that is often asked is, sure, there's opportunity, but is there ROI? Is it actionable? What do I go do? Why is this more important than that? And there's a lot of that. I would say this is actionable. This has clear ROI. It's sized. It's prioritized. This is more important than the thing at the top is the most important, and so on. So, if you want to add, or I can walk through the page.
I just add one other thing, that often it's so complex to act on things, right? People tend to go for, let me find the 5,000 people that I can impact. Well, now you need to put in workflows. You need to do alerts. You need to do interventions. You got to train a huge amount of stuff. We are saying take one intern and apply them, and you can affect those 19 people, right? How can we make it very simple so that the organizations don't, if I dare I say, don't have an excuse to not act on this, right? That's our job. Analysis should turn into something so simple, so actionable, so quantified and prioritized that it's possible for well-meaning people to actually act on it. Great analysis, which is at a high level, actually doesn't turn into action.
I think there's some interesting things on this page, and it's worth spending a minute or two talking through a little bit of what's on here. The font might be a bit small for those in the back. I won't belabor it, but I do want to talk through it a little bit. So the top line, complex patients who don't see a doctor. So these are defined as those with 9 or more chronic conditions, and in the year prior to their admission, they had 0 or 1 primary care visits. So you show this to a physician, clinician. Frankly, you show this to any of the non-clinicians in the room. You say, well, that's quite obvious. They're really sick people, and they're not seeing a doctor. These are definitely people we should be worried about. You're not telling me anything new. We are telling you something new here, though, with this particular line, is we care about them the most of any particular microsegment. And we have a financial impact here that we can attribute to this group. The next one down, the young and complex, is people in the 30s with many complex conditions. Okay, the third one down, hip fractures with heart failure. So this is actually not a cohort I've ever heard talked about in the research. Now, it's a very small group, so a 500-bed hospital will probably see about 1 of these patients every year, and therefore you need to do analyses like we did on 30 million patients to be able to statistically say that this is actually an important group. You can start to tease out, or my physician colleagues can start to tease out what the story might be here. You have a heart failure as a extreme exacerbation of hypertension and cardiovascular disease. You couple that with a hip fracture, which probably demobilizes you a little bit, might put you in a wheelchair, makes caring for yourself or visiting your doctor difficult. You start to see the story, and you start to see how a care manager visiting them in their home can be effective, and in fact might be the only way to really be effective with this group.
And if I may add one other thing, this is where things like APCDs, all payer claims databases, the efforts around HCOP, the data, free the data, all these initiatives come into play. Because for any one of these hospitals, the microsegments would be too small to be able to analyze. It would not be statistically significant. It is precisely because you're looking at 30 million that you find these patterns. And that's what we need to do. Go look at our whole countries and maybe internationally eventually and find out all the microsegments that are actionable.
Great. Well, I won't read the rest of the items on this page. I think they each have their own story. We did for each of these different cohorts talk with care managers and clinicians about what are the types of things that you might go do. I talked about them at the very beginning of this talk. They're frankly many of the same things: increasing access to primary care, making sure people in wheelchairs have the ability to get to their doctor's appointments, taking their medication, managing psychosocial issues. So that's the top 10 quote unquote list here, and we're going to do 2 deep dives for you. So I guess 5 more pages of results, and then. So one on the very top line here, complex patients who don't see a doctor. We'd like to learn a little bit more about that group. What can we learn? What else is interesting there? And then we'll talk about the patients with diabetes. I believe some interesting research there too. So this chart here shows. Ignore the bar on the left. What this chart is showing, if you look at relatively healthy people, Charleston sum of 0, these are relatively healthy individuals. If you look at their increase in annual cost as a function of how many primary care visits they have in the year following their discharge, if they go to the doctor one time, you'd expect a $163 increase, 2 times $496. The more times they see a doctor, the more coincident that is to the fact that they actually have increased health needs. But the one on the far left is interesting because the people who don't see the doctor at all their health costs rise quite considerably. And the question is why? Let's answer that question. And and an inference might be how do we get them to see the doctor one time or 2 times, and can we make an impact on that particular bucket? The numbers on this particular page are not high. This is your very healthy group. We risk adjusted it, but if you look at other increasingly risky patients, the difference between not seeing a doctor at all and seeing a doctor one time is can be in the thousands of dollars. These are the things that people who are not seeing a doctor at all are doing, disproportionate to those who see the doctor one time. They have a lot more ED visits. They have a lot more ambulances. They have a lot more CT scans, X-rays, things that are ordered in the ED. So I think this has been discussed. I'll admit it. This is not much of this in this particular analysis here has been talked about in the literature too. That is this. One of the major failures of our primary care is access and people overutilizing the emergency department. But here at least we've got a quantification for certain cohorts of the population. What kind of investment we might be willing to make sure that they get to a primary care physician and not use the emergency department.
And if I may add something, so it's kind of, we know that people are overusing emergency departments, but there's a fundamental difference between that and being able to go to the decision makers and say, this is how much money it costs us if we don't follow up to get somebody who had an inpatient event and is in the group of psychiatry. If they don't come back, it's going to cost us $200, right? When you can quantify things and put proportions on it, they become real. Just saying that people are overusing emergency rooms is not actionable. That's what we are asking all of you to do. Turn these healthcare analysis into something that people can actually comprehend and act on rather than broad themes.
Great. Well, so we have 2 pages left, and they're my favorite 2 pages. I'll set it up that way. So diabetic ketoacidosis. So if you're not aware of this condition, it is specifically prevalent in juvenile onset diabetes. Often for individuals who don't know they have diabetes yet, will end up in the hospital with ketoacidosis as a life-threatening event, really that has to be treated in the hospital. Then you're discharged from the hospital after an event like this. You have to take your insulin every day, at least as of 2013 for the rest of your life. So it's a serious condition. And it's 1 out of every 200 or so inpatient events. So this is not a horribly rare condition. And what we have on this chart here is the incidence of readmissions for these patients 1 week, after 2 weeks, and so on, up to a full cumulative year, where the average readmission rate over 12 months is 37%. This is for the cohort that are not taking their insulin on a regular basis. They're not filling their insulin scripts. So 37% is an extraordinarily high and regrettable readmission rate. We compare this to the cohort who have consistent compliance to their insulin, and the readmission rate there is 20%. It's still quite high, but a tremendous drop. And it proves, I think, what's clinically well known is that this group of people have to take their insulin, and it's life-threatening. These readmissions are not just expensive, but a readmission for ketoacidosis is a life-threatening event. And so this here quantifies how much we would, as a health system, as healthcare, a set of healthcare providers, we'd be willing to invest in any given one of these patients to make sure that they adhere to their insulin, that they're taking it every day, and that we avoid these readmissions. We'd be net neutral if we spend $4,500 for each patient. And so care managers can help here. This is exactly the kind of thing that care managers can do well. It's a home visit within the first few days. Make sure that as you visit the house, the insulin pump is on the patient. Make sure that they understand the severity of the situation, that they understand and they have a plan for how they can refill their insulin, all these things.
Actually, let me add something before we go to the next slide.
Yeah.
One comment and one question. Some of the stuff you saw here, I'm sure you've seen before. Probably not the quantification, but you've seen before. The way I see it is, if we showed you only surprising things, you should be very worried about this analysis methodology, right? Because what everybody believes to be true should show up in such an analysis as well. But the question is, are there also surprises? Because if surprises come up in the same analysis methodology, you probably should pay it credence. Does that sound fair? So I'm going to ask you guys a question, because I don't want you to walk away from this session saying, I knew everything these guys said. Young women versus old men. How many people think young women would be better at complying with their insulin medication as opposed to old men? Could I get a raise of hands? How many people? Okay, a few people. And how many people think old men would be better at complying with their medication than young women? Well, you guys went 50-50 approximately, okay. So that didn't, if you could go to the next slide. Okay.
Well, indeed, the worst offenders here are middle-aged women with a 50% lack of compliance to insulin and 50% readmission rate. That's a terrible failing of our healthcare system. And in fact, women in general, if you see the bottom here, are actually worse in general at complying with insulin. They're much more likely to end up back in the hospital for this than men. I asked an endocrinologist colleague of mine why this was the case. Because it's generally believed, this is a smarter audience than most, but it's generally believed that men are the worst at taking their medications. But here we have something a bit counterintuitive. And he thought about it for a while. He didn't know. He hadn't seen this before, and he didn't know. And then he gave me a hypothesis on why this was true, and he just asked that I simply not repeat it. So I'm going to share it with you here today, although I won't give his name, so I think that balances it out. I mean, he said to me, what is the easiest way, if you're one of these patients, what's the easiest way to lose 30 pounds? You don't take your insulin. Insulin is the chemical in the body that absorbs blood sugar. And so, of course, what we also see here, of course, if you want a 1 in 2 chance of ending up back in the hospital with a life-threatening condition, what do? You don't take your insulin. So,
and I was telling Tim, like every young woman that comes out of a doctor, it would be great to show them that slide and say, look, yes, you might lose some weight, but you're going to be back in surgery. Like 1 out of every 2 of you is going to be back in the hospital. Is it worth that risk? But many people don't know about this pattern, so they are not acting on it today, for example.
Yeah. No, everyone we show this to is surprised, not pleasantly surprised. These are kind of terrible statistics. But that's our presentation. So I think we might have a few minutes. We're happy to take questions, comments, and other. Please contact us. Our email address is there. If you're around later today, we also have an office hour. I'd be happy to see anybody. Thank you.
Thank you.